Hello and welcome back to Count to 10. In today's episode, we're going to cover pulmonary circulation as part of our respiratory physiology topic. Now, this section made me really happy when I was going through respiratory physiology because it was short with quick learning objectives to cover. There's only 4 learning objectives in total, and they're just talking about what the pulmonary circulation is, what the difference between the pulmonary and the systemic circulation is, what the factors that determine pulmonary vascular resistance, and then our weird last learning objective is talking about the drugs that can affect pulmonary vascular resistance. We'll finish the podcast with talking about some SAQs, which there isn't many of, so let's dive straight in.
1, 2, 3, 4.
The first learning objective is outline the anatomy of the pulmonary and bronchial circulation. We can start talking about this by looking at the vascular anatomy, and to make it simple, we have the right ventricle, which gives its outflow to the main pulmonary artery, which then divides into 2 pulmonary arteries, the left and the right, which then goes into the pulmonary capillary network, and then empties out into the 4 pulmonary veins that join in into your left atrium. The structural features of these are that they are thin-walled vessels with little smooth muscle that are very distensible. The also key characteristic is that it's a short pulmonary artery. In general, the pulmonary circulation is a low pressure system that needs to be highly elastic with thin walls. And the reason is it's the only circulation apart from the systemic circulation that takes all of the cardiac output. The pulmonary artery and veins all travel in a bronchovascular bundle, which is connected with the bronchi that are near it, the nerves and the lymphatic. There are really 2 important clinical considerations with the pulmonary circulation. Firstly, because of the pulmonary circulation being low pressure, there's a delicate balance between the hydrostatic pressures and the oncotic pressures within the pulmonary capillaries. This means that any imbalance can lead to a tendency to develop edema, and you can see this on a chest X-ray with peribronchial cuffing. The other clinically significant feature is that the pulmonary veins drain into the left atrium. They're continuous with the left atrium and therefore can have some amount of cardiac myocytes. And this is important to recognize as it's a common reason why people develop atrial fibrillation. Looking now at the bronchial circulation, by contrast, this only takes 1% of the cardiac output. Remember last episode we said that the bronchial circulation is one of the few causes of a physiological shunt. The bronchial circulation is very similar to the pulmonary circulation. It has arteries, capillaries, and veins, but the bronchial circulation supplies the conducting airways. So this is anything that's terminal bronchioles and above. The bronchial circulation arises from the systemic circulation, and it's different depending on which side you look at. On the right side, a bronchial artery arises from the intercostal artery. On the left side, there's 2 bronchial arteries, and these have separate origins that come off the aorta. Not all of the bronchial circulation is shunted. 2/3 of the blood from the physiological shunt will drain from the left atrium back into the left ventricle, but 1/3 of the blood from the bronchial veins will actually go back into the systemic circulation. Some of the blood from the bronchial circulation will also join directly into the pulmonary artery. So to summarize pulmonary and bronchial circulation, we have the features of the circulation being thin-walled vessels with little smooth muscles that are easily distensible. The pulmonary artery receives blood from the deoxygenated blood from the systemic circulation, the deoxygenated blood from the bronchial circulation, and some oxygenated blood from the anastomosis between the bronchial circulation and the pulmonary circulation. The pulmonary veins receive oxygenated blood from the pulmonary capillaries, deoxygenated blood from the interpulmonary shunt, deoxygenated blood from the bronchial circulation, majority of it, so this is the 70% or the 2/3, and then deoxygenated blood from the Thebesian veins or the Thebesian circulation of the heart. Now our next learning objective is discuss the difference between the pulmonary and systemic circulation. This is probably the one learning objective you have to know well because it's been asked a few times as SAQs. The way I would conceptualize this learning objective is probably best formed in a table with systemic circulation and pulmonary circulation. You can also think about factors as one column heading, and within factors we can then subdivide this with vascular anatomy, the pressures in the system, the resistance in the system, the blood flow of the system, and then the overall function of the system. So when you think about the vascular anatomy, you can say that the systemic circulation has thick walls, contains lots of smooth muscle, is minimally distensible, and has a long aorta. And this is all in contrast to the pulmonary circulation, which as we've said, has thin walls, has little smooth muscle, is easily distensible, and has a short pulmonary aorta. The systemic circulation is obviously a high pressure system with a map that's 6 times higher than that of the pulmonary circulation. The normal pressures in a pulmonary circulation are 25/8 with a map of 15. And remember, it's affected by the hydrostatic gradient of gravity. We can also look at the inlet versus outlet pressures between each circulation. So for the systemic circulation, the inlet pressure is low in the right atrium at 2, and then the outlet pressure is high in the left ventricle at 100. So the gap is 98. Compare this to 15 in the RV and 5 in the left atrium, so the gap is 10. So we can say that the inlet versus outlet pressure is 10 times more in the systemic circulation compared to the pulmonary circulation. The overall resistance, therefore, is also higher in the systemic circulation, and we can measure resistance by using units. So these are commonly Wood units, or we can measure them in dynes per second per centimeter to the power of 5. This is a key fact to remember, and it commonly comes up as multiple choice question. So the pulmonary circulation has 10 times less resistance compared to the systemic circulation. So the Wood units are around about 1 to 2 in the pulmonary circulation and approximately 10 to 20 in the systemic circulation. If you're measuring this as dynes, it's around about 100 to 200 in the pulmonary circulation and 1000 to 200 in the systemic circulation. That resistance is mainly distributed in the systemic circulation at the arterioles, because that's where the biggest pressure drop occurs, but is evenly distributed throughout the whole pulmonary circulation. The factors that can affect that resistance we'll talk about in our next learning objective, but looking at the blood flow as a whole, we've already said that the systemic circulation receives 5 liters and so does the pulmonary circulation, so they both receive exactly the same cardiac output. However, the distribution of the blood flow is different. In the systemic circulation, the distribution of blood flow will largely be garnered by tissue metabolic demand and a little bit by gravity and pressure. However, in the pulmonary circulation, gravity and pressure have a huge role in determining where the blood flow goes. There's also the effects of the cardiac cycle, autoregulation in terms of hypoxic pulmonary vasoconstriction, and then the effects of intrathoracic pressure. So there's a lot of unique things that make the distribution of blood flow in the pulmonary circulation different to the systemic circulation. And this is reflected in the function of those two systems. The function of the systemic circulation is largely to deliver oxygen and nutrients to all tissues and remove waste and carbon dioxide from those tissues. The function of the pulmonary circulation has many roles, and this kind of goes back to that acronym or mnemonic we had, which was pre-admits filter, when we talked about the non-ventilatory functions of the lung. So the role of the pulmonary circulation is to be a blood filter, a blood reservoir, to house metabolic enzymes, to be an immunological barrier, to provide acid-base balance, to provide a route for drug extraction as well as drug inhalation, to conduct thermoregulation, and then the main function is essentially to bring blood for gas exchange. So at the crux of it, that's what the pulmonary circulation is doing, gas exchange, but it has all those additional roles attached to it. Now, by far the most important learning objective in this pulmonary circulation topic is discuss the pulmonary vascular resistance and the control of pulmonary vascular tone. This is really key to understand. Remember, vascular resistance is an expression of the relationship between driving pressure and flow, so it relates back to Ohm's law. Pulmonary vascular resistance is a resistance in the vasculature within the pulmonary circulation. So you can write this as an equation and say that PVR is the pulmonary driving pressure divided by the cardiac output. The pulmonary driving pressure is the pulmonary artery pressure minus the pulmonary venous pressure. So we put some numbers in. we can then say that 15 minus 5 divided by 5 is equal to 2 millimeters of mercury per litre per minute. And that's where we get the normal number for PVR being 2 Wood units. Or if you express it in dynes, it's 100 to 200 dynes per second per centimetre to the power of 5. Blood flow in the pulmonary circulation is normally laminar because it's a low pressure system with not much resistance to it. So while you would think that the Hagen-Purcell equation is probably the most important determining factor for PVR, it's not the only factor, and that's what makes pulmonary circulation unique. The other thing that makes pulmonary circulation unique with regards to PVR is that because it's a low pressure system with not much in terms of muscular arterioles, the PVR in the pulmonary circulation is equally distributed between the arteries, capillaries, and veins. The low resistance allows that cardiac output to be distributed evenly with the effects of hydrostatic pressure that we're going to talk about, but the goal is that the resistance is low so that we can allow gas exchange to occur as efficiently as possible. Because remember, when we spoke about the functions of the pulmonary circulation, the main one was to allow gas exchange to occur. So everything we do has to be in one form or another trying to optimize this. Now, there's lots of ways which you can think about breaking down the factors that affect PVR, but for me, the most simple way to think about it is passive factors and active factors. There's 3 passive factors, and these are the pulmonary blood flow, the lung volume, and the effects of gravity. Then there's a whole host of active factors, and in no order of priority, these are your autonomic nervous system control, your hypoxic pulmonary vasoconstriction, your blood chemical factors like your PCO2 and your pH, your hormonal factors, your drug factors, and your viscosity factors, all relating back to the Hagen-Purcell equation. So just going through them step by step, we can start with the first passive factor, which is pulmonary blood flow. Now, normal conventional thinking would state that if you increase blood flow, you're going to increase your driving pressure, so you're going to increase your pulmonary vascular resistance. This is not what happens in the pulmonary circulation, and the reason is because there is distension and recruitment of pulmonary vessels. This is something we spoke about in the last episode, and this is unique to the pulmonary circulation. So as we increase either our pulmonary artery pressure or our pulmonary venous pressure, or both increase, our pulmonary vascular resistance actually decreases. What happens is, at low pressure volumes, with the increasing pulmonary blood flow, we get opening of previously closed vessels called recruitment, and this is the main factor that decreases pulmonary vascular resistance in low pulmonary vascular pressures. And at high pulmonary vascular pressures, we get an increase in the caliber of vessels that are already opened. So they become wider and more distended. And this is the main factor at high pulmonary pressures, and this is called distension. This is shown in a classic graph in West, which has on the y-axis pulmonary vascular resistance, and on the x-axis it has both arterial or venous pressure. Both PVR are decreasing in both the arterial and venous system as those pressures increase, and it's an exponential decrease. The reason we have this inbuilt kind of mechanism in the pulmonary circulation is the reason we normally increase pulmonary blood flow is to increase gas exchange. So it's to do with improving gas exchange to meet the metabolic demand. Now, all of a sudden, if we were to increase blood flow and increase resistance, we would therefore impede our ability to provide good gas exchange. So it would be a counterintuitive mechanism. What we want to do is, with increasing blood flow, we want to allow an increased amount of gas exchange to occur. So we want that resistance to be lower, and that's why this mechanism is there in the pulmonary circulation. The next passive factor is lung volume. Essentially, lung volume plays a role in changing pulmonary vessels. We look at 2 main pulmonary vessels that are important with regards to PVR. And these are alveolar vessels, so the vessels that are within alveoli, and extra-alveolar vessels. These are the vessels that are adjacent to the alveoli. Now, alveolar vessel caliber is mainly determined by alveolar pressure because these are vessels that are within the alveoli. Extra-alveolar vessel caliber is determined by the radial traction of the lung. So typically what we say is that at low lung volumes, we lose the radial traction of the lung, and so we increase our extra-alveolar vessels collapsing. So PVR is increased by the extra-alveolar vessels having a decreased caliber. At high lung volumes, we're increasing the alveolar pressure, and so we're decreasing the alveolar vessel caliber and we're increasing PVR that way. So we need to find a balance where we're not at low lung volumes and we're not at high lung volumes. And where that occurs is the equilibrium, which is commonly FRC. At FRC, we say that the PVR is the lowest and the best balance is achieved between extra-alveolar and alveolar vessels. Again, you can see this graph in West's, and it's a classic U-shaped graph. Now, our last passive factor is gravity. We've already spoken about gravity in our last episode when we spoke about West zones. So just a quick recap, remember West zone 1 was where there was increased alveolar pressure that was greater than the arterial pressure. West zone 2, the difference in arterial and alveolar pressure varied depending on the respiratory cycle, and this led to a Starling resistor effect. West zone 3 was where there was normal conventional flow returning, so flow was determined by arterial minus venous pressure, and West zone 4 was due to the effect of radial traction on the extra-alveolar vessels. So those are the main passive factors, and it moves us on to talking about the active factors. The main active factor that you must know is hypoxic pulmonary vasoconstriction, and it does what the name says. In hypoxic conditions, there is increased vasoconstriction and an increase of PVR. The actual reason why this occurs hasn't fully been brought about yet, but we think it's probably due to the effects on calcium channels and potassium channels in hypoxic states. And the important thing is that what causes this reaction is a low alveolar partial pressure of O2, not a low blood partial pressure of O2. So it's hypoxia, not hypoxemia. There is minor contribution to this mechanism occurring with a low partial pressure of O2 in mixed venous blood. So the main mechanism why this occurs is because of a low partial pressure of alveolar O2, and the secondary reason is due to a low partial pressure of mixed venous O2. The response becomes marked when the alveolar partial pressure drops below 70 millimeters of mercury, and it's characteristically described to occur in two phases. You have a first phase, which is the initial rapid phase, where you get a massive increase in pulmonary vasoconstriction occurring within 5 minutes, and then a plateau occurs. And then you have the second phase, which is around about 40 minutes later, which leads to a small further gradual increase. The max response occurs at the 2 to 4 hour mark, and then the response quickly gets obliterated as soon as there's restoration of the non-hypoxic environment. The other active factors are blood chemical factors, so a change in the partial pressure of CO2 and pH do different things in the pulmonary circulation than what they do in the systemic circulation. So a hypocarbic environment or an acidemic environment lead to an increase in PVR compared to the systemic circulation, where those things would cause a decrease in systemic vascular resistance. You also have the effects of hormones like catecholamines, thromboxane A2 that all increase PVR, nitric oxide decreases PVR, and then you have the minor effect of the autonomic system. The reason I say it's minor is mainly because it's the sympathetic nervous system that has an effect, not really the parasympathetic nervous system. The sympathetic nervous system with the A1, A2, and the B2 receptors can all do different things. Typically, the alpha-1 receptors will cause an increase in PVR through constriction, while the alpha-2 and the beta-2 receptors will cause a dilation to occur and a decrease in PVR. Other active factors are the effects of drugs that we'll talk about in our next learning objective. And then to finish off this learning objective, we can briefly touch on how to measure pulmonary vascular resistance. So the most common way would be to use a Swan-Ganz catheter. So this would allow you to estimate mean pulmonary arterial pressure and mean pulmonary capillary wedge pressure. You'd also be able to figure out cardiac output through a thermodilution technique. Now you have the numerator and the denominator in your PVR equation, and you can just plug those values in to get you an estimate of your PVR. Our last learning objective in this topic doesn't really fit in with the physiology theme because it's the only pharmacology-based learning objective that we have in all of respiratory. So it is outline the pharmacology of drugs used to treat pulmonary hypertension, including nitric oxide. Now I'm only going to briefly touch on this learning objective because we'll talk about it a lot more when we go into pharmacology, but we can start off by defining pulmonary hypertension. It's traditionally defined as the mean pulmonary artery pressure being greater than 25 millimeters of mercury at rest, assessed by a right heart catheterization. It can be classified into 5 categories, that is pulmonary hypertension that's caused by idiopathic causes, by left heart disease, by lung disease, by chronic thromboembolism, or by an unclear source. You can also classify the severity of pulmonary hypertension by looking at the mean pulmonary arterial pressures. So a pressure between 25 to 40 is considered mild, 41 to 55 is considered moderate, and severe is considered more than 55. You can also classify it using functional assessments, so whether there's no limitations, whether there's minimal limitations, whether there's limitations that are moderate, or in the worst case where they're unable to perform any physical activity at all. What you're looking for with those functional assessments is symptoms of right heart failure. And in worse scenarios, it can lead to cor pulmonale, causing a biventricular failure. Now, the pharmacology part of this learning objective is actually quite important and interesting. Although it's not really brought up much in the SAQ section, it can be a favorite opening question in a Viva setting. The way nitric oxide works is that, simply put, it leads to smooth muscle relaxation. In the vascular endothelium, L-arginine is converted into L-citrulline by nitric oxide synthase. This releases nitric oxide, which then goes into the vascular smooth muscle and causes an increase in the cyclic GMP activity. You get an increase in G kinase and a decrease in calcium, which leads to relaxation of that smooth muscle and therefore vasodilation. The way you give patients nitric oxide is you give it via the inhaled route, and it's typically dosed in parts per million. Because it doesn't last that long, the effects are mainly in the pulmonary vasculature, and it doesn't have many systemic vascular effects. The reasons you would give it is in any case where you're trying to improve VQ matching and improve arterial oxygenation. The nitric oxide can have severe side effects. It can lead to the development of severe pneumonitis or pulmonary edema occurring, and that's because the way that nitric oxide is rapidly oxidized into NO2, and this can react with water to form nitric and nitrous acids. The other drugs you can use to help with pulmonary hypertension are prostacyclins, specifically PGI2s, and these can be administered both IV or subcut, and they can essentially cause a vasodilation occurring. You can use ACE inhibitors, which help to decrease pulmonary vascular resistance. You can use phosphodiesterase inhibitors, which impede the breakdown of cyclic GMP and cyclic AMP. You can use calcium antagonists like nifedipine. You can use an endothelin receptor antagonist. So that concludes talking about the learning objectives in this episode, and we'll move on and look at some of the past SAQs. Now, the first SAQ is from 2022, and it's the most likely SAQ that you will get, and it is briefly outline the differences between the pulmonary circulation and the systemic circulation. This had a 53% pass rate, and you have to understand that this question is asking you to briefly outline. So this means quick facts with good headings. The headings as per the examiner report were anatomy, hemodynamic variables, blood flow distribution, vascular resistance, and function. You need to put a lot of information in each one of those headings, and the best way to do that is with a table. So just like we discussed, the best table would be one that has systemic circulation, pulmonary circulation, and factors. So if I was to structure this answer, my first factor would be aim. So what is the aim of this circulation? So this is your brief statement that shows your understanding. The aim of the pulmonary circulation is to provide gas exchange along with all the other minor factors. The aim of the systemic circulation is to provide O2 to areas and remove waste. Then my next factor would be anatomy. Here I would say the pulmonary circulation is a low pressure system with thin walled vessels with low resistance to enable laminar flow and to best match its aim, which is for gas exchange. The systemic circulation has thick walled vessels with high pressure and arterioles to control that resistance, and it's not very distensible at all. My next heading would be hemodynamic variables. So here I put inlet versus outlet pressure, SVR versus PVR, pulsatile flow versus non-pulsatile flow, the effects of gravity, and then I'd put a little clinical tab in and talk about the effects intraoperatively and of surgery. And this doesn't have to be many points, it can just be one point. For example, talking about a pneumoperitoneum affecting the systemic circulation, and IPPV affecting your pulmonary circulation. Then my next big heading would be regulation. Here I would talk about local regulation, autonomic regulation, metabolic regulation, and then physical regulation. You can divide it in the pulmonary circulation by active and passive factors. And the key thing you want to highlight here is how the effects of hypoxia, hypercarbia, and acidemia differ between the pulmonary circulation and the systemic circulation. Then finally, the last tab would be functions. And depending on how you've structured your answer, you could put this with the aims with the functions here. So you would say the functions of the pulmonary circulations is to perfuse the lungs, provide gas exchange, be a filter, be a blood reservoir, to metabolize drugs, to control acid base. The functions of the systemic circulation would be to remove CO2, remove waste, provide O2, and match tissue demand. So the key here, unfortunately, is a lot of numbers. Numbers like remembering what the Wood units are, remembering what the inlet versus outlet pressure is, remembering what the differences in maps are. So to best describe this question, it's really a rote land answer. Then the next SAQ was from 2002, which was outline the physiological factors that influence pulmonary vascular resistance. And this is literally taken from what we talked about in our learning objective. Here we divide the question into active and passive factors, and the examiner report stated that in your answer you needed to have the approximate normal values with the correct units, the relationships between PVR, pulmonary perfusion pressures, and cardiac output, the effects of distension and recruitment, lung volumes and gravity, discuss oxygen effects, so this is hypoxic pulmonary vasoconstriction, and then additionally you could talk about things like nitric oxide, blood viscosity, autonomic factors, and the effects of hormones. So if you think about it in terms of a brief opening statement, passive factors being your pulmonary blood flow, so your pulmonary venous and arterial pressures, your lung volumes, talking about your alveolar and extra-alveolar vessels, and the effect of gravity in terms of west zones, and then your active factors being hypoxic pulmonary vasoconstriction, the effects of blood chemicals such as CO2 and pH, the effect of hormones, the effect of autonomic nervous system, mainly a sympathetic nervous system, and the effects of drugs. And if you forget those, you can think about the Hagen-Purcell equation and think about what factors have I missed in that equation. That should easily give you a pass mark for this question. Those are really the only two SAQs from the ANZCA exam. There is an SAQ from the KICM exam, which was asked in 2016, which was describe the physiological factors that affect pulmonary artery pressure and write short notes on the use of nitric oxide as a pulmonary vasodilator. Really, what this question is trying to get you to understand is that pulmonary artery pressure is affected by the pulmonary blood flow and the pulmonary vascular resistance. So if you can write this in your opening statement, you can then say that it'll be affected by the same factors that affect PVR. Additionally, it'll be affected by factors that affect pulmonary blood volume. So these are things like venous return, left ventricle outflow, right ventricle outflow, gravity, and then again relating back to recruitment and distension. The real key with knowing how nitric oxide works is just relating it back to the mechanism of action of how it increases the activity of guanylate cyclase, which decreases the intracellular calcium, which leads to smooth muscle relaxation. It's delivered by the inhalation route, and you can divide this section up into brief notes about the pharmaceutics, the pharmacodynamics, and the pharmacokinetics, knowing that the side effects are quite severe. This concludes a pretty short topic of pulmonary circulation and a straightforward topic for once in respiratory physiology. We have 2 more topics in respiratory physiology to go, and that is applied respiratory physiology and measurement, and hopefully we'll have those 2 episodes out before the end of the month. And that special podcast with my SAQ tips I'm planning to release in the last week of February. So until then, thanks for listening, best luck with your studies, and we'll catch you next episode.